Hello, everybody. Welcome to today's interview. And I have to say, this is quite an honor and a real special privilege to have Judi Lund Person, who is the Vice President of Regulatory and Compliance for the National Hospice and Palliative Care Organization. So, Judi, welcome.
Thank you so much. I'm really delighted to be here.
Well, we are thrilled that you're here, because you can certainly bring a lot of knowledge to our listeners who are both medical professionals as well as caregivers and people in the general community, because there's so many myths and misunderstandings about hospice. But before we get into, I've got a few questions I want to ask you. I do want to just give everybody a little bit of a background about what you do, because it is quite a lot. So as the VP of Regulatory and Compliance for the National Hospice and Palliative Care Organization, she works out of Alexandria, Virginia. Judi works daily as a key contact with the Centers for Medicare and Medicaid Services on hospice payment policy, Part D, which I'm sure she'll explain what that is, survey and certification, contractor management, and program integrity issues. Judi also works daily with hospice providers and state hospice organizations on the ever-increasing array of regulatory and compliance issues, and translates complex regulatory language into actionable plain English for hospice providers. So first and foremost, thank you for translating all this into plain English for those of us that desperately need that.
Absolutely. Glad to help with that.
Okay, wonderful. So what I'd like to do is just sort of I think so many people hear about hospice. Some people think it's free. Some people think it's way too expensive. Can you tell us a bit about the history of the Medicare hospice benefit?
Sure. And so I think we should start by, I want to start by giving a little bit of a disclaimer myself. Which is that I've been in hospice since 1980, so before there was any sort of Medicare involvement, and I was in North Carolina for 22 years working in hospice before I moved to the Washington area. So interestingly, a lot of people think that hospice is a place, and so that's the first myth I want to really dispel, that hospice is provided wherever patients are, and that could be a patient's home, a nursing home, an assisted living facility, a box under the bridge, a homeless shelter, wherever a patient is, that's where hospice can be provided. So it's not necessarily a place. Now, that being said, there are also hospices who have facilities. So hospice inpatient facilities, hospice residential facilities, but typically that is for a very small percentage of the patients that are providing care to patients in the community.
Exactly. In fact, the hospice I work for is a perfect example. Our hospice home, we actually have two. Together, there are 54 beds, but we take care of about 350 patients every day. So a lot of people think it's a place where you go, and they don't understand the vast majority of our patients we're caring for, like you said, wherever they call home.
That's right. And that's a really important concept, because, you know, as we talk to patients, as we talk to Medicare beneficiaries, as we talk to people, you know, as they're getting older and they say, I don't want to die in a hospital. I want to stay home. I want to go home if I'm in a facility. So really the focus is constantly on how can we make sure that a patient dies where they want to die. That's a really, really critical piece of this.
Right.
Another piece is that hospice has been a part of Medicare since 1982, and the first hospices began providing care under Medicare in 1983. So a fairly long amount of time now, and that's you know, that also means that we are subject to the rules and regulations of Medicare, and that's a really important additional piece of this. As we talk about some of the challenges, some of them are very connected to what Medicare requires of us.
Right, right. So can you explain what that Medicare hospice benefit is?
Sure. So The Medicare hospice benefit is set up with 4 what we call levels of care. Routine home care, which is intermittent care provided by hospice professionals through an interdisciplinary approach. So that's doctors and nurses and social workers and chaplains and hospice aides and music therapists and whatever else the patient might enjoy or need to be comfortable and cared for in the last days of life. The patients who receive my hospice are required by Medicare to have a 6-month or less prognosis. That means they are judged by their physician to be closer to death, not chronically ill. So these would be patients who would be more terminally ill than chronically ill. And I think that's an important thing for us to make sure we have a distinction about. Sometimes that crossing the threshold of, with a healthcare professional talking to a patient about you are now ready for hospice, that's a really hard conversation. I know some of your other speakers have talked about the conversation between a healthcare professional and a patient is a really, really hard and really important conversation to have. Hospice providers, hospice clinicians are there to help both the patient, their family, and the healthcare provider who is trying to have that conversation.
Yeah, because doctors go to med school to make people better.
Right.
And I think it kind of hurts their feelings. They've told me, it makes them very sad, and it hurts their feelings when they can't make it better, and they struggle with those conversations.
Absolutely, it's a hard one, and so one of the things that many hospices do is they work with referral sources. They talk to doctors all the time about, here are some of the things that you can do to start conversations. Here are the questions you can ask your patients to help them understand what their disease is and where they are in the disease trajectory.
And don't you agree? I think every provider will tell you that their crystal ball is very foggy.
Absolutely.
Yeah, it's their best medical guess. So what happens if somebody lives longer than 6 months?
If they still are judged by their physician and the hospice medical director to be still within 6 months of death, at the 6-month point, they're not discharged. That is one of the myths I think we want to also dispel, is that all of hospice eligibility is based on, are you eligible for hospice services based on what Medicare requires. So Medicare requires that you be within 6 months of your end of your life. And so if you still meet that requirement, you are absolutely able to stay on hospice. Some people, I know I was a hospice caregiver, and my very dear friend lasted for a year to the day from his hospice diagnosis or from his hospice admission. And the doctor said 3 months max. He beat all the odds. He was going to beat all the odds, but he was always a hospice appropriate patient.
And I think there's another great study that was done that shows of the people eligible for hospice care, on average, if you're in hospice care, you live 29 days longer, on average, not always, 29 days longer than patients that would be eligible but are not in hospice care. And I think a lot of that is the palliative piece. We're able to manage their pain and symptoms and make them feel better, so they want to, let's hang around and have a few more experiences, right?
Absolutely. And I think a lot of times the patient who is first referred to hospice gets a lot of very intensive care from the various hospice professionals, and so there is care for the physical issues, what kind of medications is the patient on. Then there's also care for all the psychosocial issues. So that's where the social worker might be involved in helping the families cope with some of the issues. Or maybe there are some spiritual issues that the chaplain can help with. And our experience is exactly that we see once patients are attended to and their various needs are addressed. And I would not want to say brought under control, or they've got get rid of a symptom or whatever, because these are patients with very serious illness. But we've got a lot of patients who are able to live a good bit longer because of that.
That's right. And then before we move on to the next question I did want to just clarify. So if I have a 6-month or less prognosis, however, I choose to seek curative treatment, whatever that is, because of whatever the disease is, what does that mean?
Well, so if you are choosing curative treatment, you might not be ready for hospice yet. So one of the things in hospice is that in the Medicare setting, you are required to give up your regular Medicare Part A benefits. And anything that's related to the terminal illness will be taken care of by the hospice. So if you are seeking curative treatment, that would probably mean that you're not quite ready for hospice, which is very focused on comfort care.
Gotcha. Right. All right. So let me just ask this. Can you tell us a bit about the demographics of hospice care today, such as the disease mix and how long patients receive care and where hospice care is delivered? Which actually, I think you may have already touched on that last one.
Right. Exactly. So I think one of the really fascinating things about hospice is how it has changed over the years. And I say that having been around for a long time in hospice. And so it used to be that almost all hospice patients were cancer patients. Mm-hmm. And, in the early days, even in the days when I was working on my master's degree and I was doing my master's thesis, the thesis was 90% cancer and 10% all other diseases. Mm-hmm. Now it's 30% cancer and 70% all other diagnoses. So I want to make sure that we're all kind of thinking of hospice as no matter what your disease is, you are eligible if you meet the prognosis requirements. So that being said, about 22% of our patients have Alzheimer's or other dementias. Mm-hmm. And I think that is our largest disease group. But we also see patients with COPD or chronic obstructive pulmonary disease, congestive heart failure, kidney disease, and some stroke patients as well become hospice patients.
Right. Right. I was just going to say, so this is kind of an interesting point. If I were 102, no pain, no symptoms, just an elderly lady who is looking like they're declining and going to die, would I be appropriate for hospice?
Well, this is one of the really tricky things. It used to be that we would call that failure to thrive, or we would call that debility. And those diagnoses are no longer allowed in hospice because you have to be able to figure out some other thing that is going on, maybe some organ failure, something that is going on with the patient besides sort of what we call the dwindles. And so a hospice will want to look really closely at what are some of the things that are going on that make this patient eligible, like weight loss and some of the other things that would be markers that say, I think this patient is getting closer to the end of life. And that's a really important, ongoing, a really important thing for a hospice to really struggle with.
And I try to, when I'm talking with people, I try to do a few analogies such as, you can't go to the hospital and go jump in a hospital bed just because you want to.
Right.
You can't go to a cardiologist if you have absolutely no issues with your heart. I mean, there's got to be some kind of pain and symptom management issue or end of life care, related issue that causes some kind of symptoms, like you said, weight loss or whatever the case may be, because Medicare just won't pay for, we're a specialty, just like cardiologists for heart, we are a specialty, and we need to be able to address some sort of pain and symptom. And I mean, if I was 102 and no pain, no symptoms, that's not a bad way to go.
Right.
I think that might be everybody's wish.
Right. It is. I think it is everybody's wish, for sure.
But unfortunately, a very small percentage of people are lucky enough to have that kind of an end-of-life experience, which makes hospice such a wonderful benefit, because we can bring whatever the pain and symptoms are under control so you can have a much more comfortable end-of-life experience.
Absolutely.
Okay, so let me ask you this. Can you give us 3 to 4 major issues that are facing hospices today?
So, it's really interesting because there's a lot more in the press now about hospice. And so I thought it might be helpful to talk about some things based on the kind of what from the hospice perspective is really happening. And the first one definitely is, are we getting referrals early enough? So I start by talking about 50% of our referrals are for patients who stay in hospice for 17 days or less. So that's like about 3 weeks. And so when we think about the optimum amount of time that a patient is in hospice, getting everything situated, getting all the care provided, getting all the members of the team involved, working with the family, working with the patient. Normally, our hospices tell us that about 3 months is a great amount of time to be in hospice. That way, everybody is prepared when the end comes, and the family feels very supported. So when you have half of your patients come with, 17 days or less, and about 35% come with 7 days or less, then we have a really big problem with. Then what we have is what we call brink of death care or crisis care, and the family doesn't have the kind of support, and the patient doesn't have the kind of care that we really pride ourselves on. So I think getting referrals early enough is certainly one of the really big issues. And we haven't been able to move the dial on the 50% for about 15 years. So that continues to be, I think, a struggle over some time that we always want to think about and begin to figure out what are ways that we can do a better job of getting patients into hospice earlier.
And I think you would probably agree, I think every hospice across the country would agree that the families always seem to say they wish they called sooner.
Absolutely. That is almost 100% of the time they say, I wish I'd known about this, or I wish I'd come to hospice earlier. Very, very important.
Right.
I think another thing that we're seeing, and this is very, very connected to what Medicare requires of us, is the live discharge issue. So there are two parts to this, and I want to talk about it a bit so that people know kind of from the hospice perspective some of the things that are going on. So first, the patient always has the right to say, I don't want hospice any longer. We call it revoke or revocation, but the patient always has the right anytime, anywhere to say, all right, I'm done. I want to go back to the hospital for a curative treatment, or this isn't working for me, or whatever. So there's that. And that would be considered one kind of live discharge. Then other live discharges are, let's say the patient has been on hospice for 3 or 4 months, and the hospice interdisciplinary team says, this patient, we thought they were terminally ill, we got them stabilized, we provided care, we did all the things we do in hospice to provide care and services both on the medical side and on the psychosocial and spiritual side. And this patient is now stabilized or has plateaued. And so Medicare requires us to say, we are so happy that you don't need hospice services for a while. Come back at any time. But the hospice is required then to discharge the patient because they are no longer terminally ill and no longer meet the definition of being in hospice. So that's another piece. Some other sort of discharge reasons if there is a.
Well, before you move off to another one, let me just interject. We're always pretty excited when we say people graduate from hospice because we made them feel better, we got them stable, and if the doctor can't say my best guess is 6 months or less any longer, then awesome, just go live your life, and down the road when you need us, we'll be there. And my favorite example of that is One of our patients in our hospice came on our care at 101. She died at 104. And in that period of time, we discharged that woman 3 times.
Right, right.
Yeah. How great is that?
Yeah, I mean, it's fantastic that you can get hospice, and for you actually qualify for the 6-month or less prognosis, and then you stabilize, and it's very dependent on the particular diagnosis you have, as all of us know. So a really important, I think, thing, and live discharge is not necessarily a really bad thing. So important for us to kind of have the facts about why a hospice may discharge a patient is really because of the prognosis, because they move out of the service area, or because there is some issue, safety, patient safety, or staff safety issue that would be a discharge for cause.
Right. So were there some other examples you wanted to share?
Well, I wanted to share at least one more, and that is we are always watching for ways that we can individualize the patient's plan of care, or what we call the care plan. And so that includes things like how much aid services you want. Do you need help with daily living activities? Do you need help with bathing and that kind of thing? And then a discussion between the hospice team and the patient and their family about what they want when the end is near. So visits, no visits, hospice nurse or social worker, who do they want at the home or wherever the patient is. I know in my personal case as a hospice caregiver, I said, please, I don't want to be by myself. That was really my most important thing. And so that's a conversation between the hospice team and the patient and their family. And in that case, then we are watching for ways to provide visits in those last days of life, and nurses, social workers, visits when the patient is close to death. What does the family want, and how can we make sure that we are providing all the things that are really necessary for that patient and their family?
Right. Gotcha. Okay. So we hear today about scrutiny in hospice. What kinds of issues are at the forefront when outside audit organizations look at hospices?
Well, we've talked about eligibility, and eligibility is always on the list. Did the hospice provide care to the right patients at the right time? And are the patients that were seen by the hospice, were they eligible for the hospice Medicare benefit? So that's sort of number one, and that is an ongoing, every patient is different, every situation is different, every diagnosis behaves a little bit differently, so that's always on the forefront for the hospice and for the outside audit entities that are looking at hospice. I think another thing that audit firms are looking at is, did the patient stay too long in that right patient, right care, right amount of time? If the hospice has lots and lots of patients that stay 2, 3, 4, 5 years, then there might be a red flag in some of those activities as well. So, it's the combination of right patient and then right amount of time for the amount of care that's provided.
And don't you think this is important because of the baby boomers moving into the silver tsunami? There are going to be a lot of aging people simply because that's the demographic of our country. And, I think it's a great thing that hospices are being looked at with great scrutiny to make sure everybody, like you said, is admitting the right patient for the right reasons. And if they're not eligible anymore, then they need to be discharged.
Yeah, I think that's absolutely right. And, I think we're all bracing for the silver tsunami. There will be this huge increase. We see it now in Medicare, we see it in all parts of healthcare, a huge increase in the numbers of patients that will need our services.
Right, exactly. And we've talked several times about Medicare. I did want to ask you to circle back real quick. So in your bio, you work a lot about on the Part D part of Medicare. Can you explain what that is?
Sure. So Medicare has several components. So Part A is where the hospice benefits are, and that's normally your hospital inpatient services are in Part A. Part B is doctors and outpatient services. Part D is prescription drugs. And so in the hospice benefit, prescription drugs related to the terminal illness are paid for by the hospice. And so then the question is, how do hospices work with Part D plans where the Part D plan can pay for drugs that are not related to the terminal illness? And it is an ongoing discussion between the hospice community and CMS, or the Centers for Medicare and Medicaid Services, about how that all works. And it's an ongoing discussion, I think, at this point.
And I do think that's worth emphasizing, that if you have 4 things wrong with you, the one thing that is related to your terminal prognosis,
right,
the approved medications related to that are what hospice covers. If you've got 3 other things wrong with you, but those don't have any impact on the terminal illness, then those would not necessarily be covered by the hospice. And then some of those medications would be related, because a lot of people have more than one thing wrong with them. You might have cancer, but you also may have heart disease.
Right.
So like you said, it's very individualized, but that is important that people understand too, when you're interviewing your hospices and talking with the medical directors, make sure you understand which medications are covered and which are not.
That's absolutely correct. And you know, even as the hospice team, the medical director, the nurse, the pharmacist are looking at your individual situation, there may be drugs that they say, you know, we really, it's not something that is needed any longer.
Right.
And so there may be things that you would discontinue, and that's all part of this same evaluation and individualized care plan process.
And I think that I can speak personally about that, my mother, but also so many other cases that I've heard, that when patients come under hospice care and the medical team, the clinical team looks at the long list, typically a long list of medications somebody's on, when they get rid of the stuff that they were prescribed 20 years ago that they really should have stopped 15 years ago, I mean, for no other reason, sometimes that's the reason they start to feel better. It's not taking a bunch of stuff they don't need to take anymore.
Right, and I know from my own experience as a caregiver, that was the case for my mother as well. It's like all of a sudden she stopped taking things that she had been prescribed, old line drugs prescribed long ago, and she felt much, much better as a result. Exactly.
And I want to spend the last 5 minutes on the future, but I do want to just real quickly, we talked a lot about Medicare. So I'm 60. I don't qualify for Medicare, which is 65 or older or disabled for 2 years. And I also don't qualify for Medicaid. So if I needed hospice tomorrow, how is that going to get paid?
So let's talk about that for just a moment. We've got about 90% of our care is provided through Medicare because patients are older than 65. But almost all commercial insurance companies have a hospice benefit. Medicaid has a hospice benefit. So unless you have no insurance at all, then you would be considered for care provided by the hospice at no charge to you. But most every insurance company has some sort of hospice benefit as a part of their plan.
That's right.
So no matter where you are, what age you are, who has your insurance coverage, you should be able to get good hospice coverage.
That's exactly right. So yeah, I have personal, rather private insurance that has a hospice benefit. And also there are for-profit hospices and not-for-profit hospices, just 2 different models. But since the one I'm with is a nonprofit hospice, I know that if somebody's living under a bridge and they needed our care, donations that we receive as a nonprofit hospice will take care of people that don't have anything. And so, we say no one is ever denied access to hospice care due to inability to pay.
That's correct. And I don't think it matters whether you are getting care from a for-profit or not for-profit, because in my experience, both will provide care no matter what the ability to pay is.
That's right. That's exactly right. So I just think it's everybody's sort of part of your homework is, and also, can we say real quickly, a lot of people think there's this one big, huge hospice throughout the whole country. Can you speak to that?
Sure. So there are hospices in most communities all over the United States. And if they're not in your small community, there might be a hospice that serves your community from, at next larger community close to you. There are very few places in the country that don't have access to any hospice services, but most hospice care is very community-based. So it is, whatever community you're in or some other community in your state that is fairly close to you. So you've got you should have a good amount of options.
Right. I know in the county I live, there's about 10 different hospices, and a lot of people think we're all connected to the same entity.
Right.
But the analogy I usually use is faith community. So all churches are in the faith community, but they're all separate and independent, and that's how hospices are. And Judy, the number I'm thinking I last heard was there are 5,300 hospices in the United States?
Well, we usually use the Medicare number, which is about 4,200.
Okay.
So 4,200 hospices certified for Medicare, that is providing Medicare coverage for hospice services, are all around the United States.
Gotcha. Excellent. So real quick, before we wrap up, I do want to kind of look to the future. So how should hospices prepare for the future, and how will care look differently as we look forward?
Well, so I think we all know that healthcare is changing, and all of us who work in healthcare have buckled our seatbelts to get ready for that change. So then the question is, what should we do in the hospice community to make sure we are changing along with the rest of healthcare? So a couple of things in our thinking, and one of them is don't just think about Medicare. Even though Medicare is the primary payer, look at ways that a hospice provider can support the hospital, can support other post-acute care providers like nursing homes or even inpatient rehab or long-term acute care hospitals to provide services to help patients transition from one location of care to another. Also look at pre-hospice services. So that would, we call that now palliative care. So if a person is seriously ill, not quite ready for hospice yet, but really needs some supportive services at home, what can the hospice do to provide hospice-like or hospice kind of services to a non-hospice patient? So that would be some spiritual support, some social work, some extra support, maybe a weekly phone call from the hospice or the palliative care team before the patient is really ready for hospice. So that's another way to kind of think differently about the kind of services we provide and how we position ourselves in the community.
Right, and we're one of the expert speakers is a palliative care doctor from Duke, and I think generally speaking, a lot of us in end-of-life care are trying to educate people to incorporate palliative care as soon as you have a serious illness diagnosis, so that your pain and symptoms can be managed throughout your curative path, and obviously when you're no longer seeking a curative road. But palliative care, again, palliative being pain and symptom management expertise, can make a huge difference.
Absolutely.
Yeah, for sure.
And I think another piece as we're kind of thinking about it is on the after death end. What can a hospice do to be a good community resource and community grief counseling? Could be even things like traumatic events in the community. It could be things like offering grief support services to anyone in the community that might need them. Another option for a hospice to be viewed as a really excellent community resource.
Right. Oh, absolutely. Yeah, and then there's all kinds of complementary therapies that they could look into, like music therapy, art therapy, massage, Reiki,
Exactly.
healing touch, lots of different things to help the patient as they're reaching the end of their road, but also not the end of their road, but the end of their life, but caregivers when they're reaching the end of their road because they are so tired from caregiving, you know, offering, you know, all those complementary therapies for caregivers to help keep them well so that they can care for their loved one.
Absolutely. Very, very important to stay well. So all of those things are really important parts of, I think, what we're looking at.
Absolutely. Well, Judi, my goodness, you are right there in the middle of all the regulatory changes and shifts and trends that are coming along. And we are, as a hospice community, we are so grateful that there are experts like you keeping your thumb on the pulse of what's going on so we can benefit our patients and families, because, you know, that is what it's all about, is supporting our patients and families. So for our listeners, I want to encourage you to visit the website, which is nhpco.org, and that stands for National Hospice and Palliative Care Organization. So nhpco.org. If you have no idea what hospice resources are available to you in your community, go to that website and it can certainly give you a list of the hospices available to you. And there's a whole nother just endless amount of information. A program they have called We Honor Veterans, which is a wonderful program that a lot of hospices are participating in, ours included, to meet the special needs that often veteran patients have. So it's just a fabulous resource for anybody in the country to go to try to figure out what are the resources available to me. So Judi, any parting words before we end?
Well, I also want to throw out the consumer website that we also operate called caringinfo.org, which has a lot of information on advanced directives, and if you are in a state where you need an advanced directive, you can download one for free, and all kinds of resources for consumers. And it's really intended to be a great resource for consumers who are looking for palliative care resources, end-of-life resources, hospice information, advanced care planning, any of those things. So another great website for resources.
Wonderful. That's a wonderful point. And then I will make one last point. NHPCO has a tagline that's also a little ribbon that they've been kind enough to let me use on my website. And their tagline is, "It's about how you live," which is one reason why my website is called it'sabouthowyoulive.com. But what I'm really trying to say is our medical provider, as well as I think all hospice providers, will tell the patients and the families, we're not helping people die. We're helping people live until they die, which is why that tagline is so perfect for hospice, because so many people think, as Judi said, it's typically brink of death care, and that is not what it's about. We're trying to helping people live or die comfortably, pain-free, with dignity is just the smaller part of what we do. The very bigger part of what we do is helping our patients make the most of every single day that they have.
Absolutely.
So that whoever came up with "It's about how you live" tagline was genius. They have my accolades up one side and down the other. So Judi Lund Person, Vice President of Regulatory and Compliance for the National Hospice and Palliative Care Organization in the DC area. Thank you so much for all the work you do and for your expertise today. I know all our listeners just learned a tremendous amount, and I'm sure it'll be extremely helpful, particularly to those that are dealing with these kind of issues right now. So thank you so much, Judi.
Well, thank you for having me. It's been a pleasure.
Absolutely, absolutely. Have a great day.
All right, thank you.